I've been in the cardiac ICU since 2005. I've done Ecmo for the last 8 years of my nursing career. So I've seen a lot of change in our program. I feel like our apheresis kind of comes and goes, and we see it for a while and then don't see it for a while, so I'm by no means any expert on it, but I know a lot about Ecmo. So we'll kind of talk a little bit about the basics of the physiologic concepts of Ecmo today, and just understanding how our circuit works to help you guys understand the process a little bit better. So if there's anything that you don't understand or have questions about, please feel free to interrupt me. I don't like to stand up here and just talk and talk and talk at you, so please interrupt me and ask questions. So Ecmo was originally designed kind of as a last-ditch effort for people that they didn't know what else to do for, which our viewpoint has kind of changed on that in the last several years. So it's supposed to provide temporary life support in patients with cardiac and or pulmonary failure. So we see a good combination of both, sometimes one, sometimes the other, or sometimes both. So it can be used for a variety of different things. It's very similar to the cardiopulmonary bypass circuit that's used in the OR, with the exception of that the Ecmo circuit is in and out. There's no emptying or filling, or that's the basic difference between the two. So it's what comes out goes back into the circuit. It does not treat any underlying pathology. It just allows the patient some support while the disease resolves or reverses. And typically it's been said that it's only appropriate if underlying pathology is reversible. However, sometimes it's used as simply a bridge to a decision as well. So several different indications for Ecmo can be divided into two types. You have cardiac failure, respiratory failure, or sometimes the patient will have a combination of both things. So just some basic indications. We see a lot of post-heart or pre-post-heart transplant. We see a lot of post-cardiac surgery that they're unable to wean from bypass. We see a lot of cardiomyopathies, myocarditis, MIs. The respiratory failure indications, sepsis, pneumonia, ARDS are probably the most common things. We've only done a couple of trauma patients. PEs are not super common, and then for our neonatal or pediatric patients, we have meconium aspiration, diaphragmatic hernias, and then any other congenital heart defects. So for selection criteria, there's really not, nationwide, there's really not a lot of set inclusion or exclusion criteria. There's a few things that absolutely disqualify people. Again, that reversible condition is super important. Age, size, and weight. So babies, we've done really small. I think the smallest we've done is right around 5 pounds. So we can't go too much smaller than that just because of the circulating volume. And then long-term survival, patient and family wishes. So this actually just came out as on our website. Our physicians just put this together. So this is a decision tree. So you can just you go down the line. Now these are not absolute. The physician always has the final say at the end, but it just gives you some sort of a decision tree to whether the patient is appropriate or not. So it gives them some ventilatory, if it's greater than 7 days prior to initiation. Aortic dissections are not good. So there's a few things that they're like, well, maybe this isn't a great candidate. The other big things are intracranial hemorrhage or ischemic strokes within the last couple weeks, because we have to anticoagulate these people pretty heavily. So that's definitely not a great idea. So this is never an absolute decision, but it's something that our physicians can look at to help them to decide when they get a consult. Oops. All right, so we all also see VAD patients. I know that we've done some VAD patients as well. So there's the biggest difference between an ECMO and a VAD patient is one provides oxygen support and the other is just circulatory support. So you can see on the left side there, you have your patient. You have the blue blood coming out, going to a pump back to the oxygenator, which adds oxygen and removes carbon dioxide, and then it returns it back to the patient as oxygenated blood. Whereas in a VAD, it can be on the right or left side of the heart, but it simply provides circulatory support. Does that make sense? So we've done apheresis on both systems. The VAD is an external VAD, it's not an implanted VAD. So again, just a short-term support for somebody that needs either right or left-sided support, or sometimes both. Alright, so the 4 basic goals of ECMO: we want to improve tissue oxygen delivery, transfer carbon dioxide, allow normal aerobic metabolism, and rest the heart and lungs. So we want to make sure that we're getting adequate delivery of oxygen to the cells. So we send the venous blood through an artificial membrane lung. There, the oxygen is added and the CO2 is removed, and that oxygenated blood is then returned back to the patient. So in theory, the patient's lungs or heart do not have to do a thing. We can take over complete support, or we can sometimes just do partial support. A lot of times with these patients, we struggle to reduce our oxygen demand. So these patients a lot of times will have to be sedated, sometimes paralyzed. It just depends on how sick they are, but we want to decrease their overall consumption. And then we've kind of started leaning more towards getting them awake, and I don't know how many of you took care of Mario, but when we were apheresing him, he was extubated, awake, talking, walking, all those kinds of things. So it just depends on the patient, but. So the CO2 transfer in the oxygenator is dependent on the surface area of the artificial lung. So our pediatric patients, they get the little baby oxygenators, they're just a smaller version, and then our adult patients, we go to the bigger ones. We can control their CO2. So I have a little flow meter on the oxygenator that if I turn it up, it blows off more CO2. If I turn it down, it blows off less CO2. So basically I am controlling the amount of carbon dioxide and oxygen that they're getting. So that's called the sweep gas. Basically it just blows across the oxygenator, kind of like the minute ventilation on the ventilator. So it allows the patient to have minimal vent settings. Most of them we can extubate and they can just be awake. They actually don't have to breathe, which is really creepy. There was times with Mario that he would fall asleep at night and he would stop breathing because we were efficient enough in removing his CO2 that he would just stop breathing for like an hour and it was fine. And then he would wake up again, and it's very bizarre. But so it's pretty cool that we can control a bodily function that much just based on carbon dioxide level. So. Alright, so aerobic metabolism, we know that we have to have enough oxygen delivered to the amount of oxygen that's consumed. When we don't have sufficient oxygen, we switch to anaerobic metabolism, which increases your lactate levels and makes all kinds of bad, acidosis and all that kind of stuff. So we closely watch a mixed venous oxygen saturation in the patient's blood, so we know that we are delivering enough oxygen and what's coming back to us still has enough oxygen in it. So that's kind of how we determine whether we're giving them enough support. We use that venous saturation. So resting the heart and lungs, we can do full support or we can do partial support. So a lot of times if a patient is failure to wean from the bypass machine, they'll be full support. Meaning that we'll completely take over all of their cardiac and pulmonary function. So they have very, very minimal blood flow going through their native heart. We're actually removing from one side and returning to the other side, completely bypassing. And then as they recover, we start to turn down the amount of support that we're offering. So just another diagram again, we have the patient, we have the pump, removal of carbon dioxide, adding of oxygen, and then returning back to a vein or an artery. So there's a couple different ways. We'll go to that in a minute, sorry. All right, so just basic equipment that we use. This is the newest pump that we have, the CardioHelp. That's it. Yeah, this was actually designed in the military. It was designed for transport, military transport for patients that were, out in the field. And so it's designed very small, compact, although the thing weighs like 200 pounds, I feel like, but it's not that much, but it's very heavy. So nice, compact machine. It also has, so this part right here, the red part is the oxygenator, and this is the pump on this side. So the pump and the oxygenator are built together, whereas our other circuit, they're actually separated out. Does the same thing, it's just a little bit easier. So there's the back side of it with the pump in.
What would be the excorporeal volume of that?
It depends a little bit on which circuit we use and whether it's a pediatric or adult patient, obviously. The CardioHelp has a little bit of a bigger priming volume. It's usually around 1,200 for an adult. For the babies, 300 to 500 depending on the circuit that we use.
But that's a blood prime, right?
On the adults, we typically go on with a crystalloid prime. Babies were blood primed, yeah. Some of the bigger kids, I think we've gone on with crystalloid primes, but almost always we go on with babies with a blood prime. They just don't tolerate that volume with crystalloid. So just oxygenator. This is the CenturyMag console, so this is kind of the older version of what we still use these occasionally. You'll see these more on the VAD patients. Because you can separate out, you can always add an oxygenator or you can take it away, or they're just a little bit easier. So those will be the typical equipment that you'll see. Alright, so we'll talk about the different types of ECMO support. So there is 2 different types that can be broken down various ways, but basic, we have veno-arterial support or veno-venous support. So veno-arterial is going to be your cardiac and respiratory support, and the veno-venous is going to be just a respiratory support. So the veno-venous does not offer any cardiac assistance. So we'll talk about both. So in VA ECMO, this is a good portion of our population that we see as VA. We have not had great luck with VV patients. I don't know if we put them on too late or what it is, but so the majority of our patients are venous circulation returns the blood back to the arterial circulation. So we provide both cardiac and respiratory support. So typical VA cannulation, we use the right atrium and the aorta. Dependent on the patient, sometimes they'll be in the ascending aorta, sometimes it's in the descending aorta. It just kind of depends on what the reasoning for going on is. So this obviously requires an open chest. So here's an actual patient. You can see the venous and arterial. This is a femoral cannulation. So this is used in patients that are, like for a patient that's, we're doing CPR on and they can't get them back and they want to put them on ECMO, they'll go for the femoral vessels because it can be done, it's a